Now it's my great pleasure to introduce Bob Kocher, a partner at Venrock, a venture capital firm where he focuses on healthcare and IT investments. In speaking with him, you'll know immediately that he is truly on the pulse of the future of healthcare, advising and co-funding innovative care delivery and digital health companies. He also brings a unique perspective to today's discussion regarding the future of the Affordable Care Act. He served in President Barack Obama's administration as a special assistant to the President for Healthcare and Economic Policy, where he helped to shape the ACA. And he was the only physician on the National Economic Council. Prior to working in the White House, he was a partner at McKinsey & Company, where he analyzed healthcare delivery systems around the world. He is truly passionate, and I have to say, also optimistic about improving healthcare in America. Please welcome Bob Kocher.
Good afternoon. Thank you for sharing your lunchtime with us. I think we have strong signals that healthcare is actually getting better faster today than it ever has in America. And so I am excited about both the care that we can all receive today and how much better it will get for more people over time. I say that for a couple reasons. I now live in California, where I spend my days working with entrepreneurs who want to bring product insight, bring data, bring technology, bring new ideas to healthcare to make healthcare better. And I live in a place where we're seeing the hospitals, insurance companies, employers, and patients actually want to make healthcare better faster. So I come to you with joy that we're seeing this happen. I'd observed that in just the last 5 years, there's actually been 1,000 new startups created in just healthcare IT and services. There's been $10 billion of incremental venture capital put into the healthcare economy. We've seen widespread adoption of technology, and with technology comes all that data. And one of the neat things that's occurred is that there's the Health Data Initiative, which has liberated more data just in the last year from HHS than the entire history of HHS prior to last year. So now we can, for the first time, know prices, quality, referral patterns, which medications work for which patients, find people for preventative care and get them engaged. There's amazing things happening with technology and data. Two other things that give me great optimism are an influx of proven technology entrepreneurs who've said, I figured out how to track us, I figured out how to sell you an ad, I figured out how to engage you in a game. I want to now work on something important like healthcare. And so just in the last few years, we've seen executives from Facebook, Google, Apple, Trulia, LinkedIn, all create new healthcare companies, and with them come engineers and product people who know how to make really great technologies to make healthcare better. The last thing is we're on the cusp of a host of really interesting technologies that have many easy-to-imagine applications to healthcare. So whether it's big data and machine learning to look for irregularities or make sure you're on the right clinical treatment path, or things like virtual reality to help train doctors on how to be better. We have many things that are just coming to the market that I think undoubtedly will change the way in which you experience healthcare in 5 years. Let me look back a little bit to give you a sense of why I feel this way. First, the Affordable Care Act, despite all the angst that it may have caused some of you who worked in this room, it's working. We've covered 20 million more Americans, and those Americans now, for the first time, can go to a doctor and be able to not pay for it, be able to get access to specialty care, are protected from catastrophic economic disasters should they get sick. And so this is a good thing. Many people have Medicaid, many have commercial insurance. There's been net gain in employer-sponsored insurance, and so more people have health care through their work and take advantage of the tax deductibility of health care to gain access to health care as well. On the cost side, despite lots of worries that we'd have great inflation, we've had the slowest 5 years of cost growth in really distant memory. And we actually have premiums today, despite what you may have read, that are lower than the CBO predicted when we passed the ACA in the individual market. On quality, today when you leave a hospital with certainty, you will have a discharge plan, an appointment, and your medications. And that's led to thousands of Americans who haven't been readmitted for preventable things to hospitals, and great attention and coordination of care. A lot more patients are on higher quality health insurance plans, and there's a lot more attention to data, evidence-based medicine, and treatment guidelines than we've had before, which is making us have learning loops to help us not repeat mistakes that we made in the past. Now, there are a bunch of things we can do to make the system work better, and so I'm going to talk to a few of those now. The 4 important policy priorities that we will all face for our next generation and the next Congress will also face immediately is how to make exchanges work better, how to make the markets work better, how to deal with the marketplace, so the hospital market pricing power in particular, that leads towards upward price pressure without a demand side that can necessarily push them back down. Governor Leavitt talked about the new payment models. One of the central important parts of the ACA is the movement over the next decade from fee-for-service payment models where doctors and hospitals are paid for each thing they do to systems where instead they're paid a lump sum or a bundle or some form of value-based payment where they're rewarded for good outcomes at lower cost. How do we design those in ways that brings people in and doesn't create unexpected consequences? And then the last thing is, what do we do to save more money faster? Healthcare in America is crazy expensive. $15,000, or actually more than that, for a family of four. That's nearly half of the median American wage. It's growing at 5% a year, which is the new slower growth rate. We have to make healthcare more affordable, or we'll crowd out lots of other important things in our economy that we don't want to crowd out. So we have to make the system more productive. So let me talk a bit about each of those for what you might do as policymakers to make these work. On exchanges, we should first remember that if anybody has bought individual insurance before 2014, it was a terrible experience. You sent in forms, you might have had to have a medical exam, you waited several weeks, then you got a mysterious price and you couldn't really ask questions. The policy might have a name, but it meant nothing to you, and all the details were in 75 pages of 10-point font that you couldn't understand. Today, when you buy insurance, you can go to a website which now works, you can select bronze, silver, gold, it says what the price is immediately, and you know what you're going to get. So it's a massively better experience than the old paper-based system we had before. That said, the market's not been as dynamic as one would have thought. We haven't built an ecosystem like Amazon or eBay where there's lots of choice and lots of competition and downward price pressure. So there's some things we can do to make that market work better. When we passed the ACA, we knew it would take a few years to have stability in the risk pools, get enough people in, get enough experience, and so we had some policies designed to stabilize the markets, and those were risk adjustment, reinsurance, and risk corridors. As you may know, there's been lots of contention over risk corridors, but my argument is that we should extend these three policies for a few more years to create stability in the marketplaces. Another topic where we had great debate, and I think a tweak could help, is something called age bands. Today, when a young person buys insurance versus an old person, there's a 3-to-1 ratio in those prices, which means that if you're older, you get a really good deal on your health insurance, and that's good. Older people have more healthcare costs, they're sicker, they need it more, and so you like to have affordable coverage for people who are older. The challenge is that if you're young, like most of this room, you're paying more than you did before. And so if you created a broader spread, you would have lower prices for younger people. That brings more young people in. That's good for the risk pool. It's good for America, I think. The downside is we'd have to do something, I think, to make policies assuredly affordable for older people, which would be a little bit more subsidy on the back end. The third thing, and this is economics 101, Professor Reinhardt would teach this on the first day in his class, is that larger markets are better. And so we set up in the ACA 50 state exchanges. And that's great because each state has some idiosyncratic differences in how they think about insurance and how they want their markets to work, but some of them are very small. And so larger exchanges are more attractive for people to sell policies into, so you'll have more competition. You'll also have more stability, because in a small pool, if a few people are sick, you can get lots of volatility in premiums. So we need to think about how to create larger markets, and that could be multi-state exchanges. It could be just changing the bidding areas for health plans so they bid on bigger regions. In California, we have several large regions plans bid on, and that's led towards actually good competition and choice, and a system where the plans make money and premiums have not grown as quickly. The final thing that I put up below the dotted line, because I doubt that we're going to want to talk about this politically, is it wouldn't hurt to think about the mandate and subsidies, because part of the challenges today is that the penalties to not buy are not anywhere close to as great as the cost of buying for many, many people. Next topic I want to take a moment to talk about is hospital market power. If you think about healthcare, most of you will think about hospitals and the big buildings that they have on all those beds inside and the amazing things that happen in an ICU in a hospital. And they're very important. They do a great job for many patients, but they're super expensive. One day in a hospital costs more than $5,000 on average in America. $5,000. That's more than any hotel you're going to stay at. And in fact, for that much money, you could have me come to your house to take care of you for the day, and we would all be happy. Those hospital prices are growing between 5% and 10% every single year. There's no other price in the U.S. economy that's growing as fast as a hospital price. The other problem is that unlike drug prices, which are easy to talk about, hospitals actually are a lot bigger part of the health economy. So it's about $1.9 trillion spent in US hospitals of the $3 trillion we spend, give or take. And that part of that slice of the pie, it's growing faster in terms of total dollars per year than any other slice. We don't have any system to really create competition for hospitals. I mean, you have one, you go to it. Very few patients will drive far or fly to some other place to go. And so with that consolidation that we've had of hospitals often buying doctors and hospitals building bigger buildings and bigger markets, we've seen prices go up faster than any other part. This is an example of data from Professor Jamie Robinson, which shows you kind of the effect, but in markets where there's not much hospital competition, prices are 30 to 50% higher for everything. And that's problematic because you as a patient have a hard time shopping. And so some things that you could do to mitigate that market power and make the demand side have a bit more say here is the first one is there's been lots and lots of mergers since the Affordable Care Act of hospitals and doctors and systems becoming bigger systems. And these are all promulgated on the promise that this is all being done for you to make your quality better as a patient and your experience better as a patient. And it's true that in some places, integrated delivery systems have done a great job at that. We often talk about the magic of Geisinger Health System in Danville, Pennsylvania, or the amazing things happening up at the Billings Clinic in Montana or Kaiser in the West, and that you can get some great outcomes when you coordinate care with specialists in hospitals and primary care and computers and share data. But a lot of times what happens when you merge these systems is you raise prices first, well before you coordinate care and create better quality. And so one thing that would certainly help mitigate the pricing tendency to do these mergers would be to say above a certain threshold, hospitals should accept Medicare prices for all payers. So they can't just jack up the prices and wait a long time to make quality better. Another important policy is today, if you go get an MRI or X-ray or your colonoscopy screening for your cancer at a hospital, you're going to get two bills and one will surprise you. You'll get a bill from the doctor that does the procedure and you'll expect that bill, but you've got a second bill called a facility fee, which could be thousands of extra dollars. If you did that at an outpatient center, not at a hospital, you might get a second bill, but it would be orders of magnitude lower cost. And so today in Medicare and in most other health insurance, there's these two payments, site payments and then the doctor payments. If you made the sites neutral, you would create a lot more dynamic market because hospitals make a ton of money on those outpatient services. Third thing is that there's a bunch of patients that get access to special drugs called 340B drugs in hospitals. They can't get them on the outpatient side. That makes no sense. We could change that. The fourth thing is when the Justice Department and the Federal Trade Commission looks at mergers, they look at a big geographic area called a hospital referral region, which makes sense for the Dartmouth Atlas, but it doesn't make sense given the shopping radiuses that patients use to shop for healthcare. When we've looked at data, most patients use a 5-mile circle. They get all their healthcares in that circle. Well, a 5-mile radius is much smaller than an HRR, which is like the entire Northern California Bay Area. And so we could use zip codes to figure out if we're limiting competition when we look at mergers. Then the last thing is, we have in the Affordable Care Act a requirement for not-for-profit hospitals every 3 years to do a community assessment for the value they create. And they write a report, and you can read them, and you should. And you'll be chagrined by the subtlety of the quality and public health benefits being created by many hospitals. So we need to actually have a way to kind of hold them accountable for like what they said they do around quality improvement. So those are some thoughts on how we can potentially make the hospital market more dynamic from a price, quality, and value perspective, and put pressure on the hospitals like every other product company has to make their product better every year. Next, I want to talk about payment models. This is data from the most recent CMS ACO data release on savings generated. And when you look at the savings generated by ACOs thus far, and I agree with Governor Leavitt, we're just in the knee of the curve of adoption here, and we're going to clearly have a lot more adoption of these models. If you look at where money's been saved, about half of the money has been generated in terms of savings by physician-led ACOs who are independent of the hospital. And that's not too surprising. When you're running a hospital, your job is to fill it up. When you're running an ACO, your job is not to use a hospital. And so there's tension in this model, right? The savings, this is the zero-sum payment system. The way it works is there's a benchmark for a Medicare patient. If we can take care of that patient for less than the benchmark, you either get half or more than half, depending on the model that you're in. That savings comes from hospitals, specialists, post-acute facilities, and most of it comes from hospitals. So not surprisingly, when a hospital runs an ACO, they have angst. They're not sure what they want to do because they lose revenue today to maybe get it back later in shared savings, but they share it with a payer. And so we have to think about that when we're designing alternative payment models, to design them in ways that we don't misalign the incentives at the front. The issue with fee-for-service is that we misalign incentives from from the point of view of patients and those who pay, because the current system pays for more stuff. In an alternative payment model, we have to make sure that we're aligning incentives with those who are delivering care, such that they're better off if they perform better from a cost and quality perspective. Some thoughts on how you would design these are the following. The first is the ACO program is Don Berwick would often describe it as an escalator. You get on and then you can move up in complexity and risk. Most people today are on one-sided risk, which is basically a very good bonus payment program. So if you don't save money, you get paid whatever you get paid. But if you do, then you'll split some of the difference with Medicare and you'll get a bonus payment at the end. And that's a good way to learn, but you don't redesign your system of care completely and adopt technology and think about it from the point of view of a patient and how you would engage them successfully in the fullness that you need to without eventually moving to a two-sided risk model. So I believe there should be a duration and a graduation to more risk as we think about this policy. The next issue, particularly for independent doctor groups, is that you can lose much more than you were paid by Medicare today. If you're in a two-sided risk model today, a primary care doctor might be getting 5 or 10% of all of the revenue of the patient, but they're on the hook for 100% of the losses. And so they could lose a lot more than they were paid, which makes it hard for groups that don't have balance sheets and reinsurance and a bunch of capital to do this. We should think about how to cap losses for those that don't have access to the rest of the money so they can afford to be in these two-sided models that I suggest that they should be in. The third thing, and this is something that when we created the ACO program, we had a lot of discussion about and a lot of angst from doctors, is that the way it's currently designed is that you have a 3-year benchmark, and then you do your 3 years. And then the next 3 years, you reset to however you did before. So if you did a great job at saving money in the first 3 years, your new benchmark will be reset at your new kind of lower price care, and you have to beat it again. And maybe you can, because there's a lot of improvement opportunity in healthcare. But over time, you're racing against yourself, and that doesn't make a lot of sense to sort of keep saying to the best providers, get better. And so we should think about readjusting to the market averages or some other benchmark after the first go-round. Then the last thing that's amazing is the rate at which upcoding occurs in our healthcare system. And in every talk that everybody all policy talks, we always have a line saying, let's root out fraud, waste, and abuse in U.S. healthcare. And we all say, of course we should. But the most egregious area is actually in the coding system. So we all passed ICD-10s to get more specific so we can be better at being sure that the patient's coded accurately. But the real way this works is you give patients more diagnosis, more codes, and that's how you get paid more. And it is breathtaking how quickly you can take admissions out of hospitals and then see the patients that are left over suddenly appear sicker in codes than they appear in reality. Examples are patients who used to be treated in hospitals for urinary tract infection being coded as sepsis. That's a $40,000 difference. It's the same treatment as IV antibiotics for 3 days. And so this subtlety in how you code has massive effects on how much you save. And today we don't have a good system to actually hold anybody accountable for this. And the Medicare RAC audits are one-off, one at a time, and not systematic enough to actually protect against this. In the Medicare data every year, you might see, those of you that read the inpatient rule, a line called coding intensity adjustment. What that means is actually adjusting for coding, upcoding, which reflects patients aging more than 1 year in a year by virtue of the codes they get. We need to think about how to adjust for much more coding intensity in the future. The last thing I'd add, and there's been a lot of discussion about this, is having some system where we can actually reward patients for engaging in their care. One of the most important healthcare measures is actually something called patient activation measures, a PAM measure, which talks about how active is a patient in knowing what their outcomes are and knowing why they're taking their meds and wanting to go follow up their visits done and sleeping and walking and doing all that stuff that we tell you to do before you leave my office. And the more I can get a patient's eyes to light up and care, the better they do. And not enough time is spent in American healthcare actually making sure the patient actually knows what they're doing and why. But when that happens, better outcomes occur. And so having some mechanism to reward, whether that's through cost-sharing differences or other things, would be important mechanisms to making these new models work better, because they require cooperation. The last thing I want to touch on for a moment is, what should you do to bend that cost curve down? What are the next set of things to do? The first thing is labor productivity, and this is a tough one. America loves middle-class jobs, jobs with benefits, jobs that pay well. Healthcare jobs have been good jobs, but we're hiring at a rate that's faster than demand is growing. And the most expensive thing in healthcare is actually the labor, the people. So for every doctor, there's now 16 FTEs running around in the health system, 9 of them are administrative. The number of non-clinical labor jobs has doubled in the last 20 years. That's the opposite of what you'd expect in a system that's getting more productive. Usually the ratio of non-productive to productive labor gets smaller every year as we get more efficient. We aren't seeing that yet in healthcare. So we have to think about how to simplify the administrative processes and how to redesign them to have, frankly, fewer people in them and more reliability so you don't have to check and fax so many things back and forth. I believe we should tackle medical malpractice. We haven't tackled it yet. Whenever I talk to doctors, the first 7 questions are versions of, why don't we fix medical malpractice? It's leading towards at least angst and perhaps some defensive medicine by doctors. I think there's lots of things that one could do to make it work better. I favor actually rewarding doctors for following evidence-based pathways as one mechanism, but there's lots of ways you could do it. And then the last thing is we have to think a lot about substitutes for hospitals. They're super expensive. We need to figure out how to do payments for care at home, how to reward doctors for using their offices for things that they would have used the ER for, to create competition on the supply side. I want to leave you with the following 4 benedictory comments. The one is, despite lots and lots of discussion and angst and the worst website launch in the history of the internet, the ACA is actually working. When you walk around to hospitals, insurance companies, patients, you see change. There's millions of people now who have access, who are experiencing technology, who are seeing systems that care differently for them. It's working. The next thing I'd say is exchanges are a good idea. They can work well. They require some tweaks, I think, to make them work better and make them more dynamic. But I don't think anybody wants to go back to the old way we bought insurance and underwrote it. And so we can make them work better. Cover California is a shining light for how you could make this work, and there's a lot I think you can extrapolate to other exchanges. The third thing is the problem is cost. If healthcare cost a lot less, we'd have a lot less angst about getting people into the markets, right? If healthcare was as reliable as any other product you bought, if it were more than 1 sigma for quality, we'd have a lot better adoption of the product and people would want to follow through with it more. And then the last thing is that the policies that we passed over the last few years, the ACA, the High-Tech Act to wire us all together, and MACRA, as Governor Levitt said, are monumental. They definitely have moved everybody from the old model to a new model. We're early in the adoption, but that new model will be one that cares a lot more about your outcomes, engages you more, thinks about it from a product perspective, and leverages technology in all the ways we have in the rest of the economy to make it work better. So I'm very optimistic for the future. I thank you for your time and attention.